happening? All four twitches are reduced but of equal height. So if someone tells you that like what will be the ratio means train of four ratio, what will be here? Train of four ratio will be calculated by T4 to T1. How will it be? It will be 1. All four twitches are of same height, so it will be 1. Okay, that's for the depolarizing. Imagine guys, I have been receiving non-depolarizing muscle relaxant. After giving non-depolarizing muscle relaxant, after 4 to 5 minutes, you stimulate the adductor pollicis. Okay, first twitch will come like this, second twitch will come like this, third twitch will come like this, fourth twitch there is no fourth twitch, or there is very less fourth twitch. So can you see guys, first twitch like this, take a second twitch like this, third twitch like this, fourth only some movement, yani ke the twitch response is slowly fading. It can be seen under non-depolarizing muscle relaxant effect. And if someone asks you what is the train of four ratio in case of non-depolarizing muscle relaxant, under the influence of non-depolarizing muscle relaxant, the train of four ratio can be either 0, yani ki if the four twitches disappeared, what will be the train of four ratio? T4 to T1, yani ki four twitches 0 by anything would be what? It will be 0. Or under non-depolarizing, adequate is usually less than 0.4, less than 0.4. That is the ratio that we need to remember. Now guys, in depolarizing it is 1, whereas under non-depolarizing it is less than 0.4. If you want to reverse the patient from muscle relaxant effect, what should be the train of four ratio? It should be more than 0.9. Then only you can reverse. Now guys, what is the first twitch to disappear? The first twitch to disappear is always the fourth twitch, and first twitch to reappear is always the first twitch. First twitch will come, then second, then third, then fourth. So this is regarding what guys? This is regarding the train of four ratio. Okay. Now again we also need to remember some miscellaneous points, like which is the intraoperative fluid of choice during surgery. It is always guys Ringer's lactate. Okay. Next, in this picture, what is being depicted? This is basically the picture of intravenous regional anesthesia. Intravenous regional anesthesia means basically you are putting a tonic way and you are giving a local anesthetic drug through the IV, and that local anesthetic drug will block this part and it won't go up. Why? Because the tonic way is not allowing it to go up. Most commonly used local anesthetic in IVRA, we have already discussed, that is lignocaine. Now what else we need to remember? What is the pressure of tonic way in the upper limb? In the upper limb it should be always 50 plus systolic BP, whereas in the lower limb the pressure should be 100 plus systolic BP. Lower limb usually has a large muscle mass, requires much pressure to block. Okay, so that's regarding what? Intravenous regional anesthesia, which is also called as Bayer's block. Okay, next, EMLA. EMLA meaning what guys? EMLA is eutectic mixture of local anesthetic. Remember guys, EMLA is usually used in pediatric cases when they are not allowing you to put an IV cannula. That's a mixture of local anesthetic. Lignocaine, what does it contains guys? Lignocaine plus prilocaine in equal concentration of 2.5 and 2.5% each. Remember, it can be given for pediatric cases except neonate. Why? Why? Because in neonates, if you apply EMLA cream, what will happen? This prilocaine will cause methemoglobinemia. Prilocaine can cause methemoglobinemia. Methemoglobinemia. Very important. Okay, that's regarding the EMLA cream. Now guys, we are discussing about the difficult airway and its management. There are some predictors of difficult airway. There are some predictors of difficult airway. For the mnemonic is obese. O stands for obese patient, B stands for beard patient, E stands for edentalis patient, S stands for snorers, and last E stands for elderly patient. They are having their own reasons for having a difficult airway. But guys, imagine if you are suspecting a difficult airway, what you have to do? You always have to follow those guidelines, difficult airway society guidelines. Plan A, plan B, plan C, and plan D. What is plan A in difficult airway guys? Always remember, before going to the plans, first you have to prepare a difficult airway set. This is the difficult airway set where you are keeping different types of tubes available, different types of LMA, different types of oral airway, different type of nasal airway, different types of laryngoscopes available, and also a tracheostomy tube with you. So guys, remember, what is the plan A for difficult airway? You go for intubation. You go for intubation with a normal laryngoscopy. At least you go for 3 attempts. Okay, 3 attempts. Okay, 3 attempts. But if your 3 attempts are failing, then you need to go for plan B. What is plan B, guys? If 3 attempts fails, then your aim should be what? I should ventilate the patient. Anyhow, I should ventilate the patient. By these 3 attempts, the patient oxygen saturation has fall. So what you should do to ventilate the patient? I will go for plan B, which is basically introducing a supraglottic airway device. Supraglottic airway, that is basically any LMA I will put, but most commonly I'll go for a second generation LMA. That's why, because it's having 2 ports and all. Other port can be used for deflating the stomach and all. Okay, so that is plan B. But imagine, guys, after putting the LMA also, this will happen. Sometimes this might happen rare. After putting the LMA, still the patient oxygen saturation is not improving. The SpO2 of the patient is still low. In that scenario, what you need to do, you cannot take on your ego and say that no, I will ventilate by LMA. No, you have to ventilate the patient. Your aim should be, we should oxygenate the patient. If LMA is not working, think more. What you will do, you go for plan C. Plan C is what? 2% technique of ventilation. What is 2% technique of ventilation, guys? Remember, in 2% technique of ventilation, one person will be holding the mask very tightly, other person will be holding the bag and pushing the air. So that is 2% technique of ventilation. Okay, that is plan C. But guys, remember, if at all after going for 2% technique also still the oxygen saturation is low, that is very rare, but if it happens again, there will be declared what? This will be declared there is cannot intubate, cannot ventilate scenario. CICV, cannot intubate, cannot ventilate scenario. This is the worst nightmare for any anesthetist. For that, you have to go for plan D. Plan D is what? You are now going for emergency front of neck access. Front of neck access with the help of scalpel or needle cricothyrotomy. Okay? Cricothyrotomy. So this is basically the DAS guidelines that we follow. Plan A, plan B, plan C, and plan D for difficult airway management. Now guys, we'll be starting with the first PYQ. A 58-year-old patient develops fever, tachycardia and hypotension post-operatively. Lactate is 5 millimoles per liter. Despite fluid and norepinephrine, MAP is 62. Urine output is 20 ml per hour. Which additional drug should be considered in this patient? Now guys, remember, whenever the patient is having a lactate of 5 millimoles per liter, that means the patient is still dehydrated and his BP is low. Whenever the patient is having hypotension, always you try to give him fluids. Okay? This patient looks in shock, so you are giving him fluids. Already fluid is given. Okay? After giving fluid, still the patient's BP is not improving. So what you will do? Now you will start a vasopressor, that is basically a norepinephrine. Okay, after starting norepinephrine also, still the patient's BP is not improving. Then what you will do, he is asking, then you will start vasopressin. ठीक है, vasopressin यानी कि basically you are adding, ठीक है, with norepinephrine you add a infusion of vasopressin. Still not improving, then you add adrenaline. But if the patient's cardiac output seems to be low, guys, then what you need to do, if cardiac output is low, you can also add dobutamine. And you can also give the patient injection of hydrocortisone. So anyways, guys, which additional drug should be considered over here? It is always vasopressin. If norepinephrine is not improving the BP, you have to go for vasopressin. Okay, that's regarding what, guys? That's regarding the next answer. Okay, next, which drug is most likely responsible for the occurrence of hyperthermia and muscle rigidity in a patient undergoing surgery while being administered anesthesia with halothane? Now guys, which drug can cause? Remember, he is given the options D, tuberculare, succinylchoanum, cisatracurium, and rocuronium. I told you malignant hyperthermia is commonly caused by all inhalational agents, and in the muscle relaxant, it is always succinylcholine that can cause malignant hyperthermia. Halothane itself can cause. Apart from that, in the muscle relaxant, it is succinylcholine that can cause. Okay. Next, a patient presented with headache, vomiting and fever. Meningitis was suspected while performing a lumbar puncture, okay, which is the last structure you will pierce just before entering the lumbar cistern. Again, these are all PYQs that was asked. So basically he is asking, in lumbar puncture or in spinal anesthesia, the common thing is you are in the subarachnoid space, you have to draw the CSF out. So what is the last layer to be pierced over here? Again guys, for layers of spinal, some say spinal instigates lethargy during anesthesia. Skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, dura, arachnoid. So last layer always will be what guys? Arachnoid membrane. Before entering the subarachnoid space or lumbar cisterna, the last layer would be what? Arachnoid membrane. Next, identify the mask that is being used commonly in COVID-19 infection cases. Guys, this mask is very easy to be identified. This is a conventional oxygen therapy mask. Okay, this is what mask guys? It's having a bag. So it is a NRBM, non-rebreathing bag. Venturi mask means there will be colors. Okay. Hudson mask is normal face mask. Nebulizer you can easily identify also. Next, which is the drug used to reverse the muscle relaxant effect of vecuronium when the renal function is normal? Basically, guys, he's asking about the relaxant. In the muscle relaxant reversal, okay? In the reversal of muscle relaxant, I told you, normally we are using, most commonly we are using neostigmine. Apart from neostigmine, we are using pyridostigmine, we are using edrophonium, we are using L-cysteine, and we are also using Sugammadex. Sugammadex is a muscle relaxant which is commonly used for vecuronium as well as rocuronium reversal. But if the patient renal function is impaired, don't give Sugammadex, directly go with neostigmine. But renal function, when it is normal, you can always go with Sugammadex, which is far much better than neostigmine. Neostigmine can cause bradycardia. Sugammadex will not cause bradycardia, and Sugammadex is more rapid acting when compared to neostigmine in reversing the effect of muscle relaxant. Okay. So that's regarding what guys? That's regarding Sugammadex. Next, in the given capnography, what does the marked area denote? This marked area is what guys? Remember, this is basically the phase 3 and it is the alveolar plateau. Alveolar plateau. I told you there is phase 1, phase 2, phase 1 is inspiratory baseline, phase 2 is expiratory upstroke, phase 3 is alveolar plateau, and phase 0 is what guys? It is the inspiratory downstroke. Between phase 2 and phase 3 there is angle called as alpha, phase 3 and phase 0 angle called as beta, and basically capnograph reading or EtCO2 is measured at this angle beta. Okay. Next, 25-year-old patient undergoes orthopedic surgery under general anesthesia. Suddenly he develops a rise in EtCO2, temperature and muscle rigidity. He's giving all the options, all the clues. Okay, which of the following drug lead to such complications? Propofol, nitrous, ethomidate or halothane. Guys, remember he's talking about what condition? He's talking about malignant hyperthermia, which is usually characterized by muscle rigidity, high temperature and all the things. So now what is the drug that can cause malignant hyperthermia? Remember, propofol does not cause. It is usually safely given in malignant hyperthermia. Nitrous is a inhalational agent safely given in malignant hyperthermia. Ethomidate, there is no chance. Only drug over here is halothane, which is an inhalational agent. Almost all inhalational agent will cause malignant hyperthermia, but the highest risk is seen always with halothane under inhalational agent category. Next guys, 35-year-old male undergoes abdominal surgery under general anesthesia, develops sudden muscle rigidity, rapid increase in body temperature, tachycardia shortly after administration of sevoflurane and succinylcholine. Again, it is a repeated thing guys. He's asking about what case? Malignant hyperthermia only. Why? Because both things are given. Sivo and succinyl both can cause malignant hyperthermia. EtCO2 in malignant hyperthermia increases in a step ladder like fashion. Okay. So remember guys, in what is the appropriate treatment for now for this patient? Guys, remember what are the options? Dantrolene, diazepam, pancuronium, vecuronium. Okay. appropriate. Remember guys, immediate management should be what? You have to first stop the triggers. If Sivo and succinyl is going, stop it. Next, you need to go for the drug of choice for malignant hyperthermia, that is IV dantrolene sodium. So that is the immediate answer. Okay, next. 55-year-old man is undergoing general anesthesia for abdominal pain surgery. Okay. Shortly after administration of non-depolarizing muscle relaxant, he develops bronchospasm, hypotension, flushing of the face. Which of the muscle relaxant is most likely responsible, guys? Remember, this is purely an allergic reaction caused by muscle relaxant. And which muscle relaxants will cause allergic reaction? Always remember the muscle relaxants which are belonging to the category benzyl isoquinoline. Those will cause allergic reactions such as atracurium, cisatracurium, mebacurium and all. Okay, those will cause, curiums will cause allergic reaction. Okay, so what are the options? Atrac, cisatrac, vec and pan. Vec and pan we don't have to look by, because these are amino steroidal. They won't cause allergic reaction. Atra and cisatra, which will you will go? Always go for atracurium. Why? Because it releases more histamine. That's as atra was releasing more histamine, then came a modification of atra, which is cisatracurium, less histamine and less laudanosine. So remember, histamine release will cause this allergic reaction, that is atracurium. Next, which of the following structures are not pierced during epidural anesthesia? In epidural, what are the structures which are not pierced? As you are passing the needle, again, we have to remember, some say spinal instigates lethargy. Just for epidural, you have to remember this only. So first layer is skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum. Once you puncture the ligamentum flavum, you are in the epidural space. So what is not pierced over here? Basically, the dura mater is not pierced. Supraspinous, interspinous, ligamentum flavum, all are pierced. Dura mater is not pierced. Next, a patient undergoes airway assessment is likely to fully open their mouth. Using the image given below, determine the Mallampatti of this patient. Now in this patient, what is the Mallampatti classification? Class 1, 2, 3 or 4. Guys, as he is opening his mouth, I am able to see the hard palate, I am able to see the soft palate and some part of the base of uvula is seen. So I think this patient belongs to Mallampatti class 3. Class 3 means soft and hard palate visible. Okay, class 4 means only hard palate visible, very difficult airway. Okay, next, which of the following are non-depolarizing muscle relaxant except? So pancuronium, rocuronium, succinylcholium and vecuronium. Pancuronium, rocuronium, vecuronium, all are non-depolarizing except succinylcholine or succinylcholium, which is a depolarizing muscle relaxant. Okay. Next, preoperative assessment of the oral cavity for endotracheal intubation in an adult is done by. So basically, before operation, how will you know that the patient is having easy or difficult airway? The most commonly that we use is Mallampatti classification. Cormack-Lehan is not used before in the pre-op area. Cormack-Lehan is done before intubation, yani during the time of intubation. While you are intubating, okay, while you are lifting the tongue, you will see that this, okay, this is the view of laryngeal aperture. That is Cormack-Lehan grading. At the time of intubation, you will see it. Okay. ASA grading is not regarding endotracheal intubation. ASA grading purely depends upon is the patient suffering with some systemic illness or not. It does not give any clue for airway. Okay. AHA is again not that case. AHA is related to American Heart Association and all. Okay. Next, in the operation theater, you observe the utilization of this particular vaporizer. Vaporizer is a device that stores a liquid inhalational agent. Which of the listed gas would you anticipate? Looking at the vaporizer, I cannot, but over here on the vaporizer, I see a yellow color. Yellow color means what you will see, guys? Yellow means yellow is sweet or yellow sevanya. Sevanya is sweet. So, Sevoflurane commonly given in pediatric cases, and it comes with a yellow color vaporizer. Desflurane, des is desi, so blue color vaporizer. Halothane, it is red color vaporizer. Isoflurane, it is purple color vaporizer. So over here, guys, what's the answer? Sevoflurane. Okay. Next, what should be done after immediate defibrillation is performed on a young male patient who was brought to the emergency department unconscious after collapsing at the railway station with no pulse and monitor showing VF. In that case, guys, you have given a shock. Immediately after the shock, what is the next thing? Will you check for the pulse? No. What you will do? You will always resume your compressions immediately after the shock. Remember, guys, resuming compression is very, very important. Don't waste or don't take time to resume compression. Don't waste more than 10 seconds for any activity in CPR to restart the compression. So always remember, compression should be continuous only. Okay. Next. In a 45-year-old patient who is undergoing pre-op assessment for a surgical procedure, which classification of Mallampati score is assigned based on the following description? Hard palate, यानी कि when the patient is opening mouth, you are able to see hard palate, soft palate, uvula, tip of uvula, tonsillar pillars. But no oropharyngeal structures are obstructing the view. यानी कि you are basically seeing all the structures clearly. Push when you see, यानी कि tonsillar pillars, uvula, soft palate, hard palate. It means Mallampati grade 1. If you see USH, uvula, soft palate, hard palate, uvula यानी कि part of uvula, tip is not seen, that is grade 2. ठीक है? Then there is grade 3 SH, soft palate and hard palate with base of uvula, and there is grade 4, that is H only, that is only hard palate. Okay, next, guys. In a 60-year-old patient who has just experienced a cardiac arrest, which of the following intervention is not a part of ACLS protocol? Amiodarone, defibrillation, adrenaline, soda bicarb. Guys, remember, defibrillation is very, very important. And remember, if it is a shockable rhythm, after 2 shocks, you start the patient on adrenaline. Okay, that is also very, very important. And next, if the patient shockable rhythm is not reverted by defibrillation, you start amiodarone, but there is no role of soda bicarb. Initially we used to give soda bicarb, but we are not at all using soda bicarb now. Next, guys, inhalational induction agent of choice in children is, remember guys, normally for any induction of anesthesia you go for IV induction, but inhalational induction, if you are going, then you need to give only one agent, and that too in children it is always sevoflurane. Sevoflurane is used for inhalational induction. Why? Because it's having a sweet odor. If Sevo is not there, you can also go with halothane, but always remember sevoflurane. Desflurane cannot be used. Why? Because it causes airway irritation and all. Which of the following is most suitable for IVRA anesthesia? In IVRA, I told you IVRA is nothing but intravenous regional anesthesia, also called as Bayer's block. The most commonly used local anesthetic is what, guys? It is lidocaine. Remember LIG of lidocaine. Lidocaine means most commonly used local anesthetic worldwide. I is it is used most commonly in IVRA, and G is Garmi. Garmi means it causes hyperthermia, malignant hyperthermia. Okay, that's regarding what, guys? That's regarding the IVRA. Next, which of the following is which of the following topical local anesthetic is commonly used for cataract surgery? Again, guys, it is proparacaine. Halothane and nitrous are not there in the option. It is always proparacaine, because halothane and nitrous are the inhalational agents. Okay, guys. Next, which of the following is the mechanism of action of local anesthetic? Remember, guys, whenever you give local anesthetic, where is it acting? In the nerve, where it is acting. But before acting in the nerve, first it will go, before entering the nerve, it will be non-ionized, and the non-ionized form, it enters the nerve and then it becomes ionized. So before entering, it is non-ionized and then ionized, and that ionized form goes towards some channels and will block those channels. What are those channels, guys? Sodium channel. Once sodium channel is blocked, depolarization is blocked, action potential is blocked, and pain is also gone. Next, in epidural anesthesia, which of the following layers is least likely to be punctured during the procedure? In epidural, what is the layers least likely to be punctured? I told you supraspinatus, infraspinatus, and remember which is the last layer to be punctured in epidural? Ligamentum flavum, the toughest ligament. Okay? Will you puncture the arachnoid? No, you don't puncture the dura itself. So how will you puncture the arachnoid? Arachnoid is after dura. So arachnoid membrane is not punctured. Next, guys, which of the following inhalational agent has a blood gas partition coefficient similar that to of nitrous oxide? But again, guys, remember, for remembering blood gas coefficient, you have to first remember MAC, the agents which are having low MAC to high MAC, low MAC to high MAC. What were the agents which are having low to high MAC, guys? The mnemonic was HISDX, or you can remember MHISDXN. Okay, so M means what? Methoxyfluorine, H is halothane, I is iso, S is sivo, D is desflurane. But we are not talking about the MAC. He is asking about blood gas coefficient. Blood gas coefficient, it will be in the opposite direction. So you can remember N, X, D, S, I, H, M. Okay? N is nitrous oxide. Nitrous oxide is having a blood gas coefficient of 0.42. Then xenon. Then xenon is not used. Next is desflurane, which is having a blood gas coefficient of 0.47. So it is always desflurane, which is having a similar blood gas coefficient of nitrous oxide. Okay, guys, that's regarding the MAC value and blood gas coefficient. Next, 35-year-old asthmatic patient is scheduled for a minor surgical procedure. Which induction agent and muscle relaxant combination is safest for this patient? Guys, remember, which could be the safest? Propofol and scoline, you don't give. Propofol, yes, can be given in asthmatic patients, but scoline will cause histamine release and worsen asthma. We don't give. Ketamine, yes, ketamine is the best IV induction agent for asthma, but D tuberculare you won't give. Why? Because it will cause histamine release. Thiopentone and rocuronium, again you don't give. Why? Because thiopentone again causes histamine release. So you're not giving. We are left out with what? Ketamine and vecuronium. Ketamine is the IV induction agent of choice for asthma, and vecuronium belongs to aminosteroidal group, which will never cause what? Bronchoconstriction, or which will not cause histamine release. So this is the best combination. Next, guys, you are in an operating room and you notice a yellow color tracing. Okay, what is this yellow tracing on the monitor? So this yellow tracing is what, guys? It is the capnography. It is the capnography. That is nothing but end-tidal carbon dioxide, which is exhaled by the patient. Okay. Next, which of the following can be used for induction of anesthesia, maintenance, and safely used for endotracheal intubation? Only one agent is there which can be used for all purposes: induction, maintenance, and for endotracheal intubation. What is that agent? Always sevoflurane for induction purpose. Remember, induction is mainly done by IV route, IV induction agents. But if IV is not possible, then you can go with sevoflurane. Okay. Next, guys, in conventional oxygen therapy, which device will deliver highest FiO2? In conventional oxygen therapy means what? The oxygen therapy without any humidifier, without any positive end expiratory pressure and all. So nasal cannula is a conventional device. Okay? Face mask is a conventional device. NRBM is a conventional device. So in that, which will produce? Remember, high flow nasal cannula is not at all a conventional device. Okay? It has PEEP and all, so it doesn't come under conventional device. So under these three, which is the commonly Venturi mask is also conventional device. So which is the which will produce the highest FiO2? Remember, face mask will deliver an FiO2 of 35 to 65%. Venturi mask will deliver an FiO2 of 24 to 60%, while NRBM produces an FiO2 of 95%. So answer is what, guys? Under conventional, it is always a non-rebreathing mask. Okay. Now, arrange the following agents based on their potency. So what's the answer for this, guys? Again, potency यानी कि MAC. MAC यानी कि basically MAC answer would be HISD is the mnemonic. But before H, you have to remember M. Okay? So remember, this is the most potent to least potent. यानी कि the agents which are having low MAC to high MAC. Methoxyfluorine is having a low MAC. Next, halothane. Next, isoflurane. Next, sevoflurane. And next, desflurane. Now we'll see. Methoxy, halo, iso, nitrous. Methoxy, iso, halo, this cannot be. Methoxyfluorine, nitrous, no, this cannot be. Methoxyfluorine, halothane, nitrous, and isoflurane. This cannot be. So more close is what? M, H, I. Okay, SIVO is not there, DES is not there, and last would be what? Nitrous only. So this is the right answer for it. Okay. Next, which is the nerve blocked in the following local anesthesia, in the following technique? Guys, remember over here what is being performed. It is always a supratrochlear nerve block, which is commonly used for orbital surgeries, or it can be used for eyebrow surgeries, eyebrow surgeries, or if the patient is having some forehead cellulitis or forehead abscess, you can also go for supratrochlear nerve block. Okay, anterior ethmoidal nerve block is not there, guys. Anterior ethmoidal nerve block is usually given for what? It is given for nasal septum surgeries, or for nasal packing you can go for this. Okay. Next, spinopalatine nerve block. It cannot be. Spinopalatine or greater palatine is usually given for some palatine laceration or some palatine surgeries. Okay, so that is supratrochlear nerve block. Okay, so guys, these were the PYQs that we need to discuss. Okay, thank you.